Good evening, everyone. Can you hear me?
Yes.
Okay, I think we should not waste time because you people have already joined. So, you want me to speak in English or Hindi? There are some people from South India, so it will be better to speak in English or Hindi is fine.
Anything is fine.
Okay. So, as we have already discussed individually with each one of you, basically जो हमारा प्रोग्राम रहेगा वो 3 months का है, जिसमें मॉड्यूल्स हैं 12 मॉड्यूल्स हैं टोटल और every Monday we will do it from 8 to 8:30 p.m. So we will not waste time. So just before we start, I would like everyone to introduce themselves. Just tell your name and your city. I think you can start now, one by one.
Myself Vidya Reddy, sir. I'm from Hyderabad.
Okay,
Hello, sir. Myself Vrinda Kamath. I'm from Bangalore, Karnataka.
great. Okay, next.
Good evening, sir. I am Mahi and I am from Pune.
Okay,
Good evening, sir. Myself Srisha Ratnam. I am from Bangalore, Karnataka.
great,
Hi,
Good
I'm
evening, sir.
Neha. I'm from Delhi.
great.
Good evening, sir.
Good evening, sir.
I'm from Qatar.
Okay,
Good evening, sir. I am from Greater Noida and Sonal.
okay,
Good evening, sir. This is Yusra. This side I'm from Delhi.
okay,
Good evening, sir.
Hello.
This is Chitra. I am from UP.
okay,
Hello, sir. It's Tejaswini, and I'm from Maharashtra.
okay,
Hi, good evening, doctor. My name is Kenny Senior and I'm from Nagaland but currently residing in Gurgaon.
okay, great,
Good evening, sir. I'm Nifa from Bangalore.
great.
Good evening, sir. This is Shaista Jabin from Bangalore.
Okay,
Good evening, everybody. I'm Bhumika from Faridabad.
okay,
Good evening, sir. I'm Astha from Faridabad.
okay,
Good evening, everybody. This side Utkarsha from Gurgaon.
okay.
Good evening, everybody. Isma Kazi from Maharashtra, Mumbai.
Okay. Everyone is introduced? Okay, so we can start now. Yes, please go ahead.
Yes. My name is Daksha Bhutani and I am from Delhi.
Okay. So everyone has finished? So I think this is a very unique thing done first time in the world and basically we can see कि पूरा इंडिया हम represent कर रहे हैं from south to east to north to west, everybody is there. The aim is कि after the completion of each module, you will get some take home messages. There are some senior dietitians and I think it's very kind of them to come and learn because जब आप एक level पे आ जाते हैं तो learn करना बहुत मुश्किल होता है. तो I just congratulate them first कि इन्होंने इतना हिम्मत की है कि वो सबके साथ आके they want to learn new technology. Technology keeps on changing. We have to basically cope up with it. So just a little bit about myself. जो मैं पहले मॉड्यूल में आपको बता रहा हूँ, दूसरे मॉड्यूल में हो सकता है कि मुझे अपने बारे में बताने की जरूरत ना पड़े. So I am Dr. Rajat Goyal. I started my MBBS in 1997. That was 27 years ago from Maulana Azad Medical College, Delhi. That time I was a 4th ranker. After that I joined Lady Harding College in Delhi. I did my MS and my senior residency there. Then I shifted to Singapore. I was in Singapore for 3 years where I did my bariatric surgery and laparoscopic training. Then I went 6 months to Taiwan for my bariatric surgery training and then 1 month to Cleveland Clinic, Florida, USA for bariatric surgery and colorectal surgery. So 2011 I came back to Delhi and from 2012 I'm practicing in Delhi NCR. I was the head of the department of Primus Hospital, Chanakyapuri for 7 years. After that I joined Akash Hospital for 1 year in it is in Dwarka, and last 1.5 years I have my own clinic and we have our own company, Indivine Healthcare Private Limited. So I decided that whatever I have learned, I want to give it back to the people and so that they can help the society. So till now I have done 15,000 laparoscopic surgeries, 1,700 bariatric surgeries, more than 1,000 laser surgeries for fissure, fistula, hemorrhoids. We were the first team to start balloon in Delhi. And till now, we have done close to 100 Allurian balloons in the last 1.5 years. And we have treated patients from 42 countries. So the module first is, before giving any diet, we should know what type of bariatric surgery the patient has undergone. So if you don't know the bariatric surgery type, the diet is different for all the surgeries. So you have to be very careful that which surgery patient has undergone. I have seen that even the patients doesn't know which surgery they have undergone. Even a lot of doctors don't know what are the differences between the surgeries. So I made it very simple to you so you can learn. I have chosen only 3 common surgeries. That is sleeve gastrectomy, the most common one in the world, where we remove a portion of the stomach. Then there is second surgery, which is Roux-en-Y gastric bypass. You can see a Y is forming. That is why it is known as Y gastric bypass. And then there is a mini gastric bypass because there is only one joint. And this mini gastric bypass, I think, is a combination of sleeve plus gastric bypass, because a sleeve is formed and then we connect it to the intestine. So I made it very easy for you to understand. And then in more modules, we will discuss the diet differences. So the first, I think, the surgery which everybody will see the patients is sleeve gastrectomy. The idea of sleeve gastrectomy is that we remove a portion of the stomach, so this stomach becomes like a sleeve, the collar sleeve or a banana. So that is why it is known as sleeve gastrectomy. So all surgeries are laparoscopic, where we use only 5 ports and we go inside the abdomen, and we have there is a gastric bougie we introduced from the mouth through the surgery, during the surgery, and it is 36 French, which is 1.2 centimeter diameter. It comes here, and taking this as the guide, we remove this stomach. This stapling is very safe because there are 3 rows of staplers here. And also the unique thing we do an intra-surgery dye test. We inflate this with the methylene glucide to see the all the staplers are fine. Then we also do suturing, which is not done by a lot of surgeons. And I also put a small pipe. So if there is any leak, we can find it through the pipe. So these 3 things are the difference between us and the other surgeons. So this is sleeve gastrectomy. And how does it affect weight loss? Because everybody thinks कि stomach छोटा हो गया तो weight loss हो ही जाएगा जब खाना कम खाएंगे. No, it is not like that. When the stomach has become smaller, this area, there is a ghrelin hormone, which is the hunger hormone. All bariatric surgeries are hormonal surgeries. So this ghrelin hormone is removed. The patient doesn't feel hungry. Initially, they don't feel like eating or drinking anything. So pre-surgery counseling is very important. When you meet the patient before surgery, explain them that after surgery, you may not like to drink or eat for a few days. That is normal. No need to worry. So this ghrelin hormone is hunger hormone produced majorly by the stomach. But after 3 to 6 months, it is again reproduced in the body from other sources. So after 3 to 6 months of surgery, patient diet will increase because now the ghrelin is again formed from extra gastric sources. This lot of surgeons don't know. Lot of patients don't know. उनको लगता है कि एक बार स्टमक कट गया तो हमारी जो भूख है वो खत्म हो जाएगी. The less in food which you are taking because of the hormone change is temporary. It is only for 3 to 6 months. So in 3 to 6 months are very important to change the lifestyle habits. Surgery is not the ultimate solution for weight loss. It is an adjunct to healthy lifestyle, healthy diet and activity, which you all are experts already. So that is why you have to understand that surgery after sleeve gastrectomy, the 3 to 6 months period are the most important period. If you can change the diet of the patient, because the smell also changes, the taste also changes, a lot of things happen to the patient. So you have to be in touch with the patient every time, telling them the decrease in diet is temporary. After the 1 or 2 months, when the patient comes to the full diet, what you can explain them that when you are on full diet, take 1/3 of the diet you are taking right now. And when we increase the phases of the diet, the first phase is 2 to 4 weeks of liquid diet, then pureed diet for 2 to 4 weeks, and then full diet for 2 to 4 weeks. Think like a new patient is like a newborn baby after the surgery. How do we give the diet? We give them sip by sip, like a newborn baby. Then slowly we give them mashed food, and slowly we give them the full diet. But the full diet is not like before. They are taking 3 heavy meals at one go. After surgery, they will take 5 to 6 meals in a divided portion, and every meal will be 1/3 of their original meal, which has to be started slowly. which I will explain you in the new next modules when we will discuss specifically the diet after bariatric surgery. This is the second surgery, which is known as RYGB or Roux-en-Y gastric bypass. See, in this surgery, in the first surgery, the stomach which was cut is removed from the body. So there is no cut stomach doesn't remain in the body. In this surgery, what we do is we make a small stomach pouch. The stomach pouch is, a lot of people make it 30 ml. So understand, if this surgery patient has undergone RYGB, they will be full after few sips of water. Even after one piece of food, they will be full. And then we connect this pouch to the lower intestine. So what happens, the food is bypassed. Like you people have traveled through a bridge, the food is bypassed into the distal part of the intestine. So the food has a new way of going into the intestine like this. And the gastric juices are coming from here. So there is another joint here. So it's like a Y. The food is coming here, the juices are coming here, and the digestion starts here. Idea is to our intestine length is 4 to 8 meters. So idea is to bypass around 2 meters so that we have 4 to 6 meters remaining. So how does this surgery affect weight loss? See, this surgery also causes hormone changes. Again, the food is going here faster. So some hormones are released, which is known as GLP-1 and pancreatic YY. They both act like insulin. So what happens is they decreases insulin resistance and they basically burn your resistant fat. And also, since the pouch is small, the patient will eat small amount at one time. Important thing to remember, the ghrelin is already here. So their diet or appetite may not be affected a lot, like in sleeve. The sleeve patients, they won't like to drink even water after surgery. But here they can drink water, but they will become full very fast because this pouch is 30 ml. This surgery now is not done very commonly. So now we have shifted to another surgery, which is known as mini gastric bypass. So the two most surgeries done all over the world are now sleeve and mini gastric bypass. Why this surgery? Because now there is again a sleeve of the stomach, like we have done in sleeve gastrectomy. The cut stomach is already there, not removed from the body, and there is only one joint. So the food comes here and the juices also go through the same limb. So this is known as mini gastric bypass. There is only one joint where we connect this loop of this sleeve of stomach to 200 centimeter of intestine ahead. Again, the hormone changes are there, GLP-1, pancreatic YY, and they act like insulin and burn fat. So these are the important three surgeries. Some results, not like bariatric surgery results, are not permanent if the patient does not follow the healthy lifestyle, they don't follow the healthy eating, and they don't start activity. That is where your role comes in the play. Okay, somebody wants to ask me, they're asking me to explain mini gastric bypass again. Okay, so this mini gastric bypass is a surgery where there is only one joint. So we create a sleeve of the stomach, but the distal stomach is already there, not removed from the body, and connected to the intestine 200 centimeter ahead. So the food is now bypassing 2 meters ahead from the intestine. The juices are also coming in the same limb, and they are not two joints, they are only one joint. So again, there is food restriction as well as there is malabsorption. Okay. So before I show you some of our patients, I want to tell you that bariatric surgery is not a solution for obesity. Bariatric surgery is only done in those patients whose BMI is more than 40 and or otherwise their BMI is more than 35 and they have diabetes or two more diseases like hypertension, fatty liver, infertility, sleep apnea, hyperlipidemia, or fatty liver, and bilateral knee joint pains. So basically, if somebody is obese, BMI more than 40, they have tried dietings, they have tried other ways of losing weight, but they are not able to do so. And their BMI is more than 40 or more than 35 with diabetes or other diseases as explained, they are the candidates who qualify for bariatric surgery. But pre-surgery counseling is very important. See, if done in the right patient at the right time, they can get very drastic results. Losing 38 kgs or losing 76 kgs, like some person has gone out from your body, it's not easy at all for the patient. There are changes happening in the body throughout. So they need constant support. They are the patients who have already taken diets with multiple dietitians, so they are very resistant. They are the most difficult patients to handle. If you can handle them properly, you can handle any patient who has come to you for diet. So, and I must tell you that this patient regained weight after 5 years. This was a patient I operated 8 years ago. After 5 years, I got a call from her that she was around 100 kgs. So we will explain in another module why this has happened. Another surgery, see, lot of weight change. This patient, see, lot of weight change. This is from, I think, UP, from Haridwar. This patient is from Delhi. Old age because of knee joint pain, and she's maintaining well. She's the person who is maintaining well, still 40, 45 kgs down. Young patients not able to get marriage. Some people want to get surgery because they are not able to get married. To become thin, everybody wants a thin wife, beautiful wife. So somehow this is a social pressure on them. Some people try VLCC, shortcut diets. But if they undergo bariatric surgery, I tell them that this is not a shortcut. You have to understand this is a lifelong commitment for being healthy. Then only I can help you. And these are some extreme cases we have done. 8-year-old boy, 74 kg, having life-threatening sleep apnea. I refused surgery for him. I said, I cannot do surgery at 8 years. His father was after me for 1 month. This guy came from Gulf, and then we did surgery. In 1 week, he lost 10 kgs and his sleep apnea was better. This lady, 70-year-old, 100 units of insulin. Again, I told her, ma'am, I cannot do surgery. It's very risky. She had a lot of problems. But after surgery, she became 96 kgs from 140 kgs. Her insulin was gone. And she lived for 5 years after that. And unfortunately, after 5 years, she developed a MI and she left this world. So, see, these are the things. Now, open to discussion. We are open to discussion. Any queries you have, you can ask me. Then I will give you the take-home messages from it. Any queries from anyone, they can post or they can discuss openly. Anything they want to ask. No need to worry that anybody will get disappointed or say, no, you are wrong. It's not like that. If you want to learn, you have to ask questions. Then only we will think that you have learned something. Anybody wants to ask anything?
Sir, myself, Dr. Fatima.
Yes.
One question I have, it's regarding Roux-en-Y gastric bypass.
Yes.
You told that the size of the stomach is cut to 30 ml.
Yes.
Does it is like the size of the pouch get increased a few months?
Yes, it can increase. In all the surgeries, sleeve, RYGV, MGB. If the patient, what happens is after surgery, patient thinks only 3 months they have to take less diet. After that, they can go back to the normal diet. Even the family wants them to get back to the normal diet. So they start testing the pouches, they start eating more and they dilate the pouches. Sleeve pouch can also dilate, RYGB pouch can also dilate, MGB pouch can also dilate. That is why lifelong follow-up is important with the bariatric surgery patient and explaining them again and again that don't worry, you can take limited food but multiple times, so you will not have any deficiencies. So somebody has asked, is there any side effects of hormonal changes? Obesity is a hormonal disease. Bariatric surgery is partially trying to correct the hormonal disease, not complete. Because even a lot of people don't know that what are the hormones which are responsible for obesity. Still, it's a method of it's a topic of research going on. Maybe we will find something new. Which sedation is given during this? All the surgeries are done under general anesthesia, where the patient doesn't feel anything about the surgery. Any other question? Somebody asked in diabetic patients. Bariatric surgery is done a lot of times as a hormonal surgery or a metabolic surgery to take care of diabetes. If the weight is reduced even by diet or by any means, the diabetes gets better. Since surgery reduces a lot of weight and the hormone changes are also there, where some hormones are released which are acting like insulin, diabetes is reversed a lot. But if the patient regains weight again the diabetes can come back. Will it cause any digestion? No. 3 to 6 meals a day ideally is good to increase the metabolism. They cannot cause digestion issue. Rarely in RYGB cases, if the patient doesn't take the right diet, they can have diarrhea because of dumping syndrome, where they're taking a lot of starchy food. That is why we have to be careful in RYGB and MGB, because here the food is going directly into the intestine. In sleep, the intestine path is normal. Any other questions?
Yeah, hi sir, myself Vrinda. So since the diet is very restricted after the surgery, will the patient suffer from any kind of deficiency? Should we give them supplements or
That is
something?
that is an excellent question. Whenever we do preoperative tests in obese patients, they are already deficient in vitamin D and B12. They are already deficient. So all the obese patients, whether they are 140 kg or 150 kg, they are already deficient. So what happens after surgery? We have to correct that deficiency. In sleeve gastrectomy, all the multivitamins are given for 3 to 6 months. After that, they are fine. But if they are undergoing RYGB or MGB, multivitamin, calcium, and irons have to be given lifelong because there is malabsorption. That has to be told to the patient before the surgery. And a lot of patients now, there are toffees of multivitamins, there are tablets, boxes specific for bariatric patients, which can be given to them. So definitely a patient undergoing bariatric surgery in preoperative test is deficient in vitamins, and sleeve gastrectomy 3 to 6 months time is enough for their deficiencies to be corrected. But in MGB and RYGB, lifelong multivitamin, calcium, and iron has to be given. We have seen patient leaving those medicines after 4 to 5 years and then say कि surgery के साथ complication हो गई because they think it is not required after 4 to 5 years, but it is required. Yes.
Okay, sir, thank you.
Question.
I also have a few doubts.
Yes,
Actually, I
please
think
go
I'll
ahead.
be getting answers to it. Yeah, nutritional deficiency is one thing, but see, whenever we help anybody lose weight, there's a tendency of them losing that charm from their face because of a lot of muscle loss also. So,
Okay.
वो भी problem आने के chances हैं, right?
May I know who is asking?
Yeah, this is Daksha Bhutani.
Okay, great. Daksha, what happens is whenever patient is increasing weight, they develop a lot of skin problems. Like
Right.
you may not have seen patients with patients 150, 160, or 170 kgs, 120 kgs. You see their forehead; it is almost black.
Right.
You see their right cheek, left cheek; it is black. So once
Right.
they start losing weight, their blackness goes away. Number one. Number
Right.
two, there is also fat in the cheek, fat under the chin. So before the surgery, we have to explain them that when you lose weight, you will become flat. So don't ask people to tell you that you have become weak because you are becoming fitter. That is
That's
second.
right. Hmm.
Number three, if the patient is taking adequate protein, that is why I force people to start protein after the surgery as soon as possible, even on the second or third day. So if you take adequate protein, they will have shininess on the skin.
That's right.
And then there are three areas you have to be careful. One is the arms, second is the lower abdomen, and third is the thighs in females, where they
Yes.
become the skin become loose. So my criteria is after 10 to 14 days, start exercises or for the arms, for the lower abdomen, for the thighs. So the skin will become tight. And then
Toning.
they may not require any other procedure. But if somebody has lost 70 to 80 kgs, they may require some plastic surgery procedure after 1 year.
Got it.
Any other?
Another thing also. See, for example, somebody whose gut is not working appropriately, we suggest them to be taking simpler foods, right? Like
Mhm.
breads, rice, और ये सारी चीजें तो already spikes up your sugar. So how are we going to deal with it? Because we cannot be giving a lot of soluble fiber.
What are you
And
saying?
see, agar if the person has diabetes, for example, and then we are suggesting them to be having simpler foods because they are going to be easy on gut, right?
No,
Gut
why?
health के लिए
Why?
rice,
I don't
bread.
know why you are giving. See, you are basically you have to understand diabetes patients has no problem with the gut. First,
No,
second
they
issue is
don't. But if they get operated, we are going to be starting with simpler foods, right?
no. That topic is a separate module that will
Okay,
be discussed
right.
in a different way because it is a complete topic. What foods have to be given, how foods have to be given, which foods have to be avoided. That is a separate module.
Understood, understood.
So
Thank you.
that is today module is you have to understand the procedure differences because if you know the procedure differences, then only you will understand the diet when I explain you diet. Yes, Tejaswini wants to ask something.
Yes, hello, sir. Sir, as you told, like there is a need to give a protein as early as
Yes,
you can, like
yes,
on a second or a third day. But it's
yes.
not like it's not better for a patient to get recovered. You know, they will feel a symptoms like nausea and vomiting, and it's related to a stomach, so it will irritable to a stomach, right? So how can
Every
we give?
every patient is different. In my practice, I have started protein on second on third day in a lot of patients. Not in all. You are right. Some people are slow. You can start then on fifth day, seventh day, but be clear in your mind that once patient is comfortable, you have to start protein in dal water. You have to start protein somehow. Like if a patient is non-vegetarian, give them chicken soup. What will happen? Their body is utilizing fat from their excess fat, but if they are not taking enough protein, they will feel weak. Then they will not walk. They will say कि मेरी सर्जरी हुई है, मैं थक गया हूँ, मैं चलूंगा ही नहीं. And if they start taking adequate protein at the right time, and they start enjoy walking, they will lose a lot of weight and they will never regain. Those patients who will not walk, those patients who will feel tired because they are taking less protein, there are ways to give them protein after the surgery. I will tell you in the module where we will discuss about the diet, how to give it. I have some tricks how to make them drink protein. And now I've made myself a homemade protein for a soft diet, where which is very easy to digest. I take it every day.
Okay,
Yes,
sir.
yes. So it's a very important thing. Yes, Fatima wants to ask something.
Sir, what are the surgical complications and what are the symptoms about it?
Great, that is very important. See, as a dietitian, understand 4 points. If the patient is a diabetic and hypertensive before surgery, okay, and a patient who has no disease, if the patient has no disease and he's talking to you, and if you think he's not feeling well, ask them to check his vitals like pulse, blood pressure, and sugar level. If all of them are normal, then you may not need to worry. But if your pulse, if the patient pulse is high, suppose the pulse is 120, 130, 140, ask them to come to the hospital immediately. So the first symptom where you have to be careful as a dietitian, when the patient calls you and say ki madam I'm not feeling well, ask them to check their heart rate or pulse. If their heart rate or pulse is more than 100, like 120, 130, ask them to immediately report to the surgeon or you report to the surgeon. Okay. Number two, if they are having severe abdominal pain, severe abdominal pain, if they are having, that can say if there is a leak from the staple line or there is a bleeding from a staple line, ask them again to consult the surgeon immediately. Don't wait. Or ask you, tell the surgeon that the patient is not well, they are having pain in the abdomen. These two are the most important things you have to take care of: high pulse rate and second, abdominal pain. And if a patient has a fever which is not responding, that is the third point you have to take care of. And the fourth point you have to take care of, if the patient has some swelling in the calf and they are having difficulty in breathing, that means there is an embolism which has gone to the chest. So these are the four life-threatening conditions which will happen only less than 1% of cases. But if you diagnose it at the right time, the patient will survive. If you don't diagnose at the right time, the patient can die. That is the difference between dieting and bariatric surgery. 4 points again: pulse rate, number two, abdominal pain, number three, fever, and number four, any swelling in the calf which is tender and having difficulty in breathing. And a patient who is diabetic and hypertensive before surgery, since their medicines are almost stopped after diet, after the surgery, because they are not taking any diet, ask them to check their sugar level and BP immediately. If the sugar is low, ask them to take glucose. All the diabetic patients post surgery should have glucon D with them everywhere they are going. No surgeon, no book will tell you this. As a dietitian, remember all the post bariatric patients who were diabetic before surgery, the most dangerous condition is low sugar, not high sugar. So ask them to carry glucon D with them everywhere they go, because that can save their life. If they're having sweatiness or they're feeling dizziness, ask them to check sugar immediately. If they cannot check sugar, it's better to give them glucon D or ask them to contact the surgeon. If they're hypertensive, Ask them to check the blood pressure. If the blood pressure is normal, nothing to worry. If blood pressure is extremely high, again ask more than 140, 90. If it is going 180, 100, ask them to consult the surgeon immediately. These are the things you have to be very careful after the procedures. Nowadays, I use Medtronic staplers, which are from US. So my staple line leak rate and bleeding rate is very minimal. Till now in 1700 surgeries, we have done 4 surgeries again because of bleeding. Touchwood, we didn't have any leak. There was one bowel injury. So 5 or 6 patients we have reoperated. But touchwood, everyone survived because we were quick. Bariatric surgery patient doesn't give you a lot of chances. First issue, just find out what is the cause. Don't take it lightly. Any other question?
Yes, sir. Other than nutrition related issues, they might also have some, like after surgery, people will go through this mental stress. They feel like they are operated. Their physical activity gets
Yes,
reduced.
yes, that is very important. Psychology support.
Yeah,
So
psychology.
before the surgery, my consultation is half an hour at least, or a 45 minutes. Ideally, a dietitian should also act like a psychologist with a bariatric patient. Otherwise, there should be a separate psychologist. In India, agar you ask the patient to meet a psychologist, they will not come back to you because they think that I am thinking they are not mentally correct.
Yeah.
So, in concept of psychologist in India is not there. Where I have trained myself in America, in Taiwan, in Singapore, there is a psychologist to basically check of their eating behaviors, how to counsel them to not do it again. Now, this thing will in India will be done by a dietitian itself. So once you meet the patient before surgery, just check their eating patterns. They may not tell you correctly. Then you have to learn to ask them to tell you the truth. Like ask them for a dietary recall for 3 days on writing. For next 3 days, ask them to send everything in writing to you. Then you will understand what they are eating or drinking because they will skip the things they think is not important, like chips and all and cold drinks, which are important. And why they eat so much when they have stress. They have image issues. Some young girls not able to get married, they have image issues. People who have got married not able to conceive, they have image issues. The people who have diabetes, hypertension, or they have become obese, they have image issues. So we have to be very sensitive with the obese patient. Never laugh at them. Never just make talk to them very softly, that you are understanding their problem, that you are not judging them. If on the first visit a patient comes and you tell them, why are you so obese, why can't you take care of the diet, that is the wrong thing. Don't you think they have tried losing weight? Do you think anybody wants to become obese or overweight? No one wants to become obese or overweight. So the first important thing for a dietitian when they meet a patient, pre-operative counseling, be supportive.
Rapport building.
Rapport build. Tell them that you are part of their family, and don't judge them. They are very intelligent people. I have patients who are CEO of the companies who have now become models, who are at a very high post like judges, lawyers. I have ministers as well. We have operated few ministers as well. So remember, don't judge them. Become a part of their family. Be polite. Listen to them. They will have a lot of things they want to tell. If they are not comfortable with their family, like parents, you can ask the family to go out and discuss with the female or a male in a separate room. Then they will open up, because the moment they will start, the parents will start shouting, सुनता नहीं है, सुनती नहीं है, खाते रहती है, खाते रहता है, कितना समझाया. But that is not the child fault. It is the fault of the patient, or the parents itself. Because the child was small, they were feeding him again food and food again and again. Child was not hungry, they were feeding him again. That happens in Indian family. They keep on feeding child. Nahi, khao, khao, khao. And when he starts eating, then they say, kyun kha rahe ho? That is a problem of the parents, and you cannot say parents that it is your problem. Again, they will get offended. So you have to be supportive with the patient as well as the family. Ask the family that I want to discuss something separately. Then the child will open up. I have seen 10 years, 11 years people 120 kgs. I have seen a boy 16-year-old 182 kgs. Just imagine, 16-year-old boy 182 kg. So you have to understand that this obesity is not going anywhere. 40% of Indians are obese, 40%. So you have to basically support them. And if you do them, this is the biggest service to society. The obese patient will never forget you for their whole life. Even your dietary patients, they may forget you after taking diet, they may join another dietitian, but once the obese patient develops a rapport with you after surgery, they will never forget you for whole life. They will become your family. Any other question? Yes, Priya ji. Priya ji is
Sir,
our
good evening.
Priya ji has joined. She is our patient. I think आप अपने बारे में प्रिया जी खुद ही बताएं.
सर पहले से बहुत बेटर फील करती हूँ मैं, बट मेरे साथ प्रॉब्लम ये आ रही है, मेरा वेट वहीं पे ही स्टक हो गया इस समय.
ठीक, आप पहले अपना स्टार्टिंग में बताएं कि आप कहाँ पर थे और कहाँ पहुँचे.
मेरा 130 था वेट जिस समय मैंने सर्जरी कराई थी. बहुत क्रिटिकल सर्जरी थी मेरी.
तो सर्जरी क्यों कराई आपने?
सर मेरे को बहुत प्रॉब्लम्स हो गई थी, बैठे बैठे सो जाती थी और चलने फिरने में भी प्रॉब्लम हो गई थी बहुत ज़्यादा.
तो स्लीप एपनी हो गया था आपको सीवियर वाला.
यस सर.
आपने डाइट ट्राई नहीं करी? डाइट ले लेते ना, डाइट से वजन कम करते.
सर एक बार किया था, उससे कोई फ़ायदा नहीं हुआ था.
तो सर्जरी कराने का क्या बेनिफिट हुआ आपको? मैंने तो आपको मना ही कर दिया था कि हम सर्जरी नहीं कर पाएंगे आपकी.
थैंक टू यू कि आपने सर्जरी करी थी मेरी.
अभी आपका वेट कितना है?
इस समय मेरा 100 के नियर अबाउट ही चल रहा है.
तो 30 kg आपने वेट लूज किया है. जितने भी
जी सर.
डाइटिशियन है नाउ, यू कैन सी देयर इज अ लाइव. I did not invite her. She has joined herself. So now you can see, after 30 kg loss, she is stuck. That weight is not, we are not losing weight. This happens to you as well when you are giving diet to your patients. They lose 5 kgs fast, 7 kgs fast, then they are stuck. See what is happening. Her activity is now very less, and also her protein intake will be less. प्रिया जी, आपका प्रोटीन इंटेक कितना है? प्रोटीन लेते हो आप शेक दिन में 2 बार?
एक बार.
तो आपको प्रोटीन इंटेक बढ़ाना है ना अपना. प्रोटीन इंटेक बढ़ाएंगे तभी तो आपकी कैलोरीज कम होगी, तभी आप वेट लॉस करोगे.
सर हम शेक के अलावा अगर जो अपनी डाइट में वैसे पनीर या मिल्क वगैरह ले लेते हैं तो उसमें भी प्रोटीन कंप्लीट होता है, नहीं होता?
होता है, बिल्कुल होता है. आप ये मान के चलें कि आपको जब भी वेट लॉस करना है, वेदर आप डाइट से करें, सर्जरी से करें या बलून से करें, नेगेटिव एनर्जी बैलेंस जब तक नहीं होगा, वेट लॉस नहीं होगा. सर्जरी के स्टार्टिंग में नेगेटिव एनर्जी बैलेंस अपने आप रहता है हार्मोन चेंजेस की वजह से कुछ महीने के लिए. उसके बाद जब आपकी डाइट बढ़नी शुरू होती है तो एक्टिविटी बढ़नी चाहिए. अगर एक्टिविटी नहीं बढ़ रही है तो वेट लॉस रुक जाएगा आपका. अगर आप एक्टिविटी नहीं कर पा रहे हैं अपनी, तो आप अपनी डाइट में कैलोरीज कम करें, मतलब कि प्रोटीन इंक्रीज करें, जिससे कि क्रेविंग नहीं आती है, पेट भर जाता है और आपकी कैलोरीज कम हो जाती हैं. और आपको एक्टिविटी थोड़ी थोड़ी करनी ही पड़ेगी. 10-10 मिनट दिन में वॉक करते रहें. पूरे दिन में अगर आप 50 मिनट कर लेंगे, रोज 2 मिनट बढ़ा लें, 10 के 12 कर लें हर बारी, धीरे धीरे आप अपने लेवल पे आ जाएंगे. यही तरीका है आपके पास अब, और कोई तरीका नहीं है इसके अलावा.
थैंक यू सर.
Any other questions? Anybody else who wants to ask anything? Age factor is there, sir, for surgery, and surgery recommended to people who are planning for. That is a dietitian Vidya has asked a very good question. See, ideal age is 18 to 65 years for surgery. As we have seen in extreme cases, we operated a boy of 8 years and also a lady of 70 years. These are extreme cases where the patients and their relative understand that how the diet will be done and they are PSC anesthesia wise fit. Ideal age is 18 to 65 years. Now, second point, pregnancy. See, once they are losing weight, you have to counsel them before surgery that chances to become pregnant will increase. Number one, the weight is, they are losing weight. Secondly, because insulin resistance is coming down, their normal hormones are working better. So if their menstrual problems are there, it will be solved and they will become more receptive to pregnancy. But since they are losing weight, write it down very carefully. For 1 year after surgery in sleeve gastrectomy, they should not get pregnant. And 1.5 years after bypass, they should not get pregnant. Because if they get pregnant, the child will not have the proper nutrition and there are chances the child born will be small for gestational age. We have a lot of couples who have undergone pregnancy after bariatric surgery and they have done well. But time limit is there. 1 year after sleeve, 1.5 years after bypass. And also this is, you will not find it anywhere in the books. It's all practical experience. And when you study a lot, then only you will find these minute things. Any other question? So I think everybody has enjoyed today's meeting. And there are some senior dietitians who can contact Amir. Amir will give you a feedback form. You can contact Amir for that. And for improvement for the next lecture, the module 2, that will be next Monday. It will be on Allurian balloon procedure, how Allurian balloon procedure is done. In between, if you have any doubts, you can tell Amir and I will solve your queries. Now, fill the feedback form, watch our YouTube channel, all the videos, and I have a homework for everyone. You make 3 diet charts. First diet chart will be, you can write it down, 1500 calories and a 90-gram protein. The first diet chart will be 1500 calories and a 90-gram protein. The second diet chart will be 1200 calories. The first diet chart is 1500 calories, 90-gram protein in a female patient. Second diet chart will be 1200 calories, 70-gram protein in a diabetic patient. The third diet chart will be 1200 calories, 60-gram protein in a hypothyroid patient. So this is your homework, and if you do it, then I will tell you later modules how this is useful for you in taking care of post bariatric surgery patients. And this chart should be 2. One should be for a vegetarian person and the other should be for a non-vegetarian person. People are asking for my mobile number. Don't worry, we can provide you later on, because a lot of times I am in surgery, I cannot pick call. You can give Amir your message and I can reach you as soon as possible. So this is a homework for you. Three things, 3 diet charts. And if somebody wants to okay, third case study is 1200 calories. I repeat the case studies again. 1500 calories, 90-gram protein in a female patient. 1200 calories, 70-gram protein, diabetic male patient. 1200 calories, 60-gram protein, hypothyroid female patient. And if somebody is good in content writing, they can write anything about bariatric surgery for 500 words, and we assure you it will be published on our channels on your name and your photograph. So if somebody is interested, they can do it. And somebody is interested in anything, they want to highlight themselves, we can give you an open platform for that. So let me ask every one of you, was this lecture useful or no?
It was
very useful.
So did you learn something new today?
Yes.
Did you learn something new?
Yes, sir.
So this interaction is very open. If anytime you think that there is an issue or you have another approach or another idea, you can tell me, because we learn from each other. I will also learn a lot of new things from you. Okay. So somebody is asking again for the diabetic diet chart. 1200 calories, 70-gram protein, diabetic female patient. See, learning is endless. I am learning for last 27 years and still I don't know everything. Every time new things are coming. Now drugs are coming, injections are coming, robotic surgery has come, laser surgery has come. We have to keep ourselves updated. People who are updated, the finances will take care of them. Learn the skill and the finances will take care of yourself. Okay, so we will meet next Monday 8 o'clock, and thank you very much for joining.